Good morning, everyone. Thank you all for attending, and thank you to everyone joining us virtually today. We have a great agenda for y'all, and today we will be doing case-based presentations on breast, GI, GU, lung, and hematological cancers. Before we get started, I want to go over some housekeeping rules. So in front of you at your table, you'll find a program guide for the meeting. In this booklet, you'll see the agenda, Wi-Fi information, non-CME and CME session information. For our virtual attendees, all sessions can be found within the agenda tab. When the session ends, please click out and go back to the agenda tab to click into the next session. And since this is a hybrid meeting, we want to be as inclusive as possible to our virtual attendees. So if you have any questions, please download the app and you can ask us questions in the Q&A tab. We also have an exhibitor bingo raffle going on, so if you didn't pick up your bingo sheet this morning, please stop by the registration table and we will give you one. We would like to invite you all to join us at the networking reception at the end of the day. That will include an open bar and hors d'oeuvres. And if you need any assistance throughout the day, please find myself or anyone at my team at the registration table. And I would like to invite Dr. Vidal to the podium to give case-based clinical updates in breast cancer.
Good morning. Although I didn't sleep in this hotel last night, I feel like I was just here. We had a symposium last night, for those of you who didn't know. Thank you, guys. I have an entire hour to talk to you about case-based updates. But there's so much in breast. I try to cover enough of everything, but some of this is really a lot review. So the first case I will talk about is, these are my conflict of interest. The first case is a 62-year-old African-American female with HER2-positive early breast cancer. She presented to a PCP to evaluate a mass in her left breast. She first noticed the mass 5 months prior, did not think much of it. In the last few months, that mass had become more pronounced, and she reported it to a primary care physician. The diagnostic mammogram ultrasound showed a hypoechoic 3.5 centimeter mass in the upper outer quadrant of the left breast, and also a lymph node in the left axilla. There were some other lymph nodes, but they looked normal on scans. Biopsy showed invasive ductal carcinoma, ERPR negative HER2/3+, grade 2, and the lymph node biopsy confirmed invasive disease. On physical exam, she is obese. She has a murmur, cardiac murmur. Lungs are clear. Breast, again, confirmed on clinical exam that mass felt more like 4 centimeters, and the lymph nodes could be palpated. She has strong family history in her sister with breast cancer, uncle with prostate cancer, and a maternal aunt with colon cancer. So questions. What factors are we to consider when deciding what treatment options? What are the treatment options for this patient? And how do we manage this patient locally and systemically? The local and systemically, I am not going to touch much on today. So in terms of the locally I'm not going to touch much on, but the systemically, the first study I will talk about is Neosphere. What is available for this patient? This patient is HER2 positive, which means a tumor is really driven by the HER2 protein. We have antibodies that are approved in this case, both of which are pertuzumab and Herceptin, and this is based on the Neosphere study, which looked at these two drugs in combination with chemotherapy and by themselves. So 4 arms, Taxol, Herceptin, which is traditionally what we did, Taxol, Perjeta, Herceptin, Herceptin, Perjeta, and Taxol, Perjeta. And essentially what it showed was that when you combined Perjeta and Herceptin with chemotherapy, those patients had a much improved pathologic complete response, which was the major endpoint. Pathologic complete response is defined as after having systemic therapy, not finding any tumor in the breast after surgery. So you're more likely to clear the breast when you combine chemotherapy and Perjeta Herceptin. I always have the conversation with my patients about the importance of putting chemotherapy with the Perjeta Herceptin. I get the question that if it's more targeted, why don't we just use the antibody? If you look at the chemotherapy, so this is for all patients. The triple negative, ER/PR negative, HER2 had a much higher pathologic complete response rate, probably in the 60 to 65%. I always tell my patients that together, the response is more exponential than you would expect if it was just additive. So there isn't a regimen that is for curable HER2 positive breast cancer that does not have a chemotherapy assigned to it. Traditionally, we've used AC, Taxotere, or taxane, Perjeta Herceptin, and then this new regimen of Taxotere, carboplatin, Perjeta Herceptin was used. The question was, were they equivalent? The Trifenia study showed that yes, and this study looked at an anthracycline, Perjeta Herceptin, versus docetaxel, carboplatin, Perjeta Herceptin, and in short, essentially it showed that, and we don't have a pointer here, that the PAF-CR rate was very similar when you use this long regimen versus this combined regimen. So right now for these patients, either of these studies, regimen can be used. In terms of safety, there was a little bit more, so we see on the left is the anthracycline with Perjeta Herceptin, and then on the right, the docetaxel, carboplatin, Perjeta Herceptin. Neutropenic fever appeared to be somewhat similar between both of them. So toxicity-wise, they were very, very similar, with a few differences like diarrhea in the Taxotere, carboplatin, Perjeta Herceptin was a little bit more. Incidence of cardiac toxicity was similar. The issue with this particular patient is she had a murmur, so that patient needed to have an echocardiogram and her heart followed very closely because one of the notable side effects of these antibodies is it can cause weakening of the heart. In terms of long-term effect, how well does it do in terms of survival? Those curves are essentially sitting on themselves. They were equivalent. So both these drugs are options. So she received TCPH. She had a lumpectomy and targeted sentinel lymph node biopsy, which revealed a 1.5 centimeter mass. So all of the tumor wasn't killed, but the lymph node was clear. What is the most appropriate options for her in the adjuvant setting? So traditionally, what we do for these patients, you give them chemotherapy combined with antibodies. After surgery, they continue the antibodies to finish off a year, and that's generally sort of a Herceptin, Perjeta Herceptin, and I'm not going to talk much about the difference between those and the studies, but what we do know is once those patients have residual disease, meaning chemotherapy wasn't able to clear the breast, these patients have a higher risk of recurrence than if they had a PAF-CR. So what is the option here? We have 4 different options. Traditionally, we've used trastuzumab to complete 1 year. There are more updated data suggests for Perjeta and trastuzumab is better than trastuzumab in some patients, especially those with lymph node positive. And then TDM1, which is an antibody drug conjugate. It is trastuzumab with a little bit of chemotherapy attached to it. It's more like a targeted bomb or no further therapy. The answer is trastuzumab or TDM1, and this is based on the Catherine study, which used a similar patient, and in the adjuvant setting, compared TDM1 to trastuzumab in those patients, and what it shows in terms of invasive disease-free survival, there was a statistically significant improvement for those patients. So HER2-positive patients who've gotten appropriate neoadjuvant chemotherapy with antibodies and has residual disease should get TDM1 over trastuzumab. I will say in that Catherine study, Perjeta Herceptin, the adjacent pertuzumab was not an option here. In terms of invasive disease-free survival, and you can look at those, and I'm going to, in terms of disease recurrence, local recurrence, TDM1 did do better. Other consideration for extended adjuvant therapy, we do have ExteNet study, which looked at neratinib. We don't talk about it much anymore. This study, neratinib is an oral tyrosine kinase inhibitor that is approved in the extended adjuvant setting, meaning these patients have gotten their chemotherapy, had their surgery, finish up their trastuzumab. We do know that there's a certain percentage of patients that will recur. We have, from the adjuvant study, 10 years, we show that 30% of those patients who've gotten the best therapy that we have still recur many years later. So we're not curing all of these patients. Can we add more? And this study, ExteNet, which added neratinib for 1 year versus placebo, and what that showed, although it's small differences, but those were statistically significant improvement, 2.5% improvement in invasive disease-free survival at 5 years. The population that appeared to benefit the most was the hormone receptor positive population. So that remains an option. With this drug particularly, diarrhea becomes a really big deal for that, so appropriate management of that. This company, Puma, has done a lot of work in order to try to give physicians ways to manage this. So instead, if this patient, instead of having a 3.5 centimeter mass, had a 1.9 centimeter mass without lymph node involvement, how would we treat her? Again, traditionally, we've given all of these patients all of the chemotherapy. Everybody, you have, as long as you had a tumor size greater than 0.5 centimeters, we threw the sink at you. And we've recognized over and over again that we may be over-treating a subset of these patients. So had a tumor been smaller, less than 2 centimeters, without lymph node involvement, what do we know now that we didn't know back then? We do know, and this is some data that Sarah Hurwitz presented at San Antonio, showing that even if you had a small tumor, if you didn't get HER2 therapy, you still did poorly. So those patients need to get anti-HER2 therapy. The question is, what and how much? Sarah Tolaney did 10 years ago, well, more like 7 years ago, presented this study, which is an APT study, and this is sort of a large single-arm study, taking this very small subset of patients, it's not randomized, and said, what if we gave those patients just half of the regimen that we were talking about earlier, the taxane with trastuzumab, and look and see how they did? Would that alone be sufficient for those patients who have smaller tumor, HER2? And it turns out that and we can just look at the 3, 7, 5, 7, and 10 years. And again, there wasn't a control arm, so we're only seeing one graph here. But at 10 years, there was a 99% disease-free survival. We don't do better than that. So we don't have to give those patients all of this chemotherapy. So that now is our standard. Sarah Tolaney and her group also, and I think this may have been presented at San Antonio maybe 3 years ago, conducted a very similar study and said, oh, well, can we beat that? Can we use TDM1, which is more of the targeted type of chemotherapy, rather than giving the patients all chemotherapy and Herceptin? And updated data at San Antonio this year to compare the outcome between the patients who got TDM1 and Taxol Herceptin. I will say this study wasn't designed to compare each of the arms. It was more of a toxicity to see whether or not, I think it was designed to show that TDM1 would be better tolerated than Taxol Herceptin. Turns out they were very similar. However, when you look at the invasive disease-free, the survival of both arms, they actually look pretty similar. So for some patients, TDM1, especially the patients where neuropathy is an issue, the taxane, the older patients, TDM1 becomes an option for those patients, and so that was updated data. So in conclusion, anthracycline taxane still remains an option. Taxotere carboplatin progesterone Herceptin is an option for patients in HER2-positive breast cancer. Patients without PCR, we need to think about what we're doing in the adjuvant setting for those patients and switch them. I know even within my practice, and I harp on that all the time, when we do have practitioners within my practice who don't do that. And that I reviewed a case recently. So we have to pay attention to that and consider chemo light for the patients. We don't always have to give everybody the big guns. All right, case 2. This is a 55-year-old female presented with abdominal pain, found to have 3 liver lesions, numerous bone lesions on PET-CT. Biopsy confirmed ER positive, PR positive, HER2 1+ metastatic breast cancer, similar to her presentation 2 years ago when she presented with early breast cancer. Her labs showed elevated liver enzymes. Past medical history, as I just spoke about, was significant for a stage 2B breast cancer that was diagnosed 2 years prior, treated with surgery, chemotherapy, and radiation. She was unable to tolerate anastrozole and stopped taking it after 6 months. Generally, the recommendation is 5 to 10 years, depending on the presentation and the genomic profile. For those patients, she only did it for 6 months. So, what is the most appropriate therapy for this patient? And we have options here: induction chemotherapy for 4 cycles because she has all these liver lesions, including liver enzymes elevated, fulvestrant and anastrozole, ribociclib, letrozole, Xeloda, and I use ribociclib there just because that's the data that I'm going to talk about. But this could be any of the CDK4/6 inhibitors, including palbociclib and abemaciclib, Xeloda, or tamoxifen. Just switch. She didn't tolerate AI. Can we just give her a SERM instead? And it's really the CDK4/6 inhibitor is the standard. We have had enough data to suggest for patients who are hormone receptor positive with first-line metastatic that any of the CDK4/6 inhibitors showed improvement in disease-free survival. There's a little difference now in terms of overall survival, with palbociclib in its study failing to show overall survival, although there is, when you tease out the data, there seems to be a patient population for whom the survival is equivalent. However, the CDK4/6 inhibitors should be standard of care for first-line metastatic. The reason I'm talking about this is when we look at sort of marketing and use data, there's about 20% of this population who is receiving chemotherapy in this setting. And most of the time, the argument is they have visceral disease, meaning the liver is involved, or they have, quote-unquote, visceral crisis, so that's a more aggressive tumor. And we want to control this with chemotherapy, and then we switch. We have more and more data that suggests that the CDK4/6 inhibitors give you enough response and survival benefit that maybe we don't need to use chemotherapy. The first study that really did, that showed that quite nicely, was presented at San Antonio this year. This is mainly an Asian study, where they took patients who were first-line hormone receptor positive, and it's called a right choice study, and randomized them to ribociclib plus an aromatase inhibitor versus physician's choice of chemotherapy. And those patients were not only hormone receptor positive, but deemed to have visceral crisis in the eyes of the physician, meaning the physician thought that this patient population was aggressive enough that I needed to probably consider chemotherapy for them. And so the whole idea of this study is, does chemotherapy for that patient surpass CDK4/6 inhibitor, or are they equivalent? What I like about this study that's different from how we practice is generally, if we give chemotherapy for those patients, we give it until we control the patient, and then we switch, regardless of whether or not they progressed, usually to a CDK4/6 inhibitor. This study says, I'm going to make it really clean. You get CDK4/6 inhibitor throughout, or you get chemotherapy throughout. So giving us a really clean look at which one is superior. Here's the difference. Blue line, ribociclib plus endocrine therapy versus chemotherapy in that quote-unquote high-risk patient. And that was statistically significant. We don't have to give those patients chemotherapy. Now, if you ask, well, this is disease-free survival, progression-free survival, yes, they're living longer, but what if that patient has a symptomatic lesion that you want to shrink? That's why we use chemotherapy. We want to control it. So let's look at response rate. So, this is median time to failure. Medium time to treatment failure favored, again, the ribociclib and aromatase inhibitor. In terms of response, overall response rate, this is a measure of partial response or complete response. That's what we're looking for the symptomatic patients. Look at the blue. They're similar. And when you look at clinical benefit rate, which also includes stable disease, it appears numerically that the CDK4/6 ribociclib arm is doing better. So those patients really don't need chemotherapy. All right, in that first-line setting. So she experienced a partial response with near complete response in the liver at 18 months when she was found to have a new lung lesion. Circulating tumor DNA performed at the time showed a p53 mutation, a PI3 kinase mutation, an ESR1 mutation. She was treated with fulvestrant and alpelisib because, again, I'm not going to go into this, but this drug, which is a PI3 kinase inhibitor, is approved in combination with fulvestrant, showing improvement in progression-free survival for patients with PI3 kinase inhibitor. Thank you very much. So she got benefit of that for about 5 months. What would you give her next? So this is a patient who had CDK4/6 inhibitor. She progressed, had a targeted therapy for PI3 kinase inhibitor, and is now progressing. What would you give her next? And the option is an everolimus type option, either with fulvestrant, which is a SERD. What it does, it degrades the estrogen receptor as opposed to inhibiting it. Abemaciclib, which has approval late line as single agent. Chemotherapy, oral chemotherapy, Xeloda, IV chemotherapy, or again, a more of a targeted approach, which is an ADC, TDXD, or Enhertu. And essentially, this is the same trastuzumab type antibody we were talking about with a chemotherapy combined to it. That chemotherapy is a little bit different, is a topoisomerase 1 inhibitor, which we have never really been able to use in breast cancer. So none of the previous treatment, the patient would have never really seen that type of chemotherapy before. And so, based on the approval, and the data that we have, the next line of therapy for this patient is at least a line of chemotherapy. And then we TDXD, and I'll show you the data for that. Destiny Breast 04 is the first randomized phase 3 study looking at a HER2 low space. So the difference between this patient and the first patient that I talked about is that the first patient had HER2 overexpressed. This patient had what we traditionally call HER2 low. She was 1+, But those patients can also be 2+ with FISH negative, considering HER2 low. Traditionally, we've had lots of data that suggests that trastuzumab by itself was ineffective in that patient population. Now, this study is saying, can I use the HER2 expression on those cells as sort of the target? Not necessarily the clinical target, but the target to bring my chemotherapy into that cell and that cell only, and see whether or not that was better than chemotherapy. And so the randomization was TDXD versus physician's choice of chemotherapy in a patient who had had one previous line of chemotherapy. So this talked about sort of that HER2 low space we were talking about. So HER2 3+ is that patient we had previously. She was considered HER2 positive. She goes down to trastuzumab, Perjeta, line of therapy, or you can be IHC 2+ with FISH positive. If you're FISH negative or IHC 1+, you're considered HER2 low. And that turns out to be about 45 to 55% of our population that we see, a very significant population, actually. HER2 positive, about 15%, and HER2 negative, about 30 to 40%. So what did this study show? That in HER2 low patients, all patients, this study also was mainly a hormone receptor positive HER2 low patients, but there was a small number of hormone receptor negative HER2 low patients also, about 60 patients in the study. But essentially what it shows is not only was there progression-free survival benefit, but there was also overall survival benefit for using Herceptin as just the target, not necessarily the clinical target, but just the target in order to bring this drug into the cell and have a more targeted approach. And the type of drug is also different. So likely, we have never used topoisomerase. In breast cancer, we use a lot of microtubulin inhibitors. And so the next one after the next one after the next one tend to, even if you're getting benefit, the benefit appears to be smaller. So this tumor is now seeing a different type of target. In terms of overall survival, again, I talked about that earlier, there appears to be significant improvement, not in all patients, meaning the ER negative and the hormone receptor positive patients. Subgroup analysis, and I'm not going to go through that, but you can see, regardless of the subgroup, all patients appears to have benefited. Side effect is very important. I remember when I first used this drug, I was surprised at the nausea associated with it. And you can see here nausea was the number one side effect on the TDXD arm. There is some neutropenia, however, the chemotherapy arm experienced more neutropenia. Diarrhea is also an issue. Importantly, ILD and pneumonitis is something that we found was higher in that population on the previous study, and even this one, where on the first study where this drug was approved, there was some grade 5s, meaning patients died because of ILD on the study, so we have to pay particular attention. The cool thing about this is when you look at any grade, about 12% of patients had ILD. There were 3 grade 5s, but most of them were grade 2, where patients were symptomatic and you had to do something about it, but you didn't have to take them to the hospital to that point. Left ventricular ejection fraction and cardiac toxicity was as expected. So what if this patient was HER2 0? What is the option for that patient? Again, traditional chemotherapy is always the option, but is there sort of a targeted approach for that patient? The answer is yeah. Sacituzumab govitecan, which is also an ADC. The antibody here is different, and I have a slide on that here. The antibody, so we have TDXD on the left, in the middle is sacituzumab govitecan, and on the right here is sort of the mechanism of action. I just put this on here so that we have an idea of what this looks like. So on TDXD, which I talked about earlier, this is a trastuzumab biosimilar antibody. What is similar about this, and for sacituzumab, this is a TROP, and TROP is a protein that is expressed mainly on malignant cells. We don't know that it hasn't really fully been understood whether or not it has any sort of clinical implication, but it's there. You can target it if you're using that as a target. And there's some similarities between those two drugs. One, the payload, the chemotherapy, both are a topoisomerase inhibitor. You can argue one may be more potent than the other, but they both are topoisomerase inhibitor. The ratio of antibody to chemotherapy is similar, 8:1 in TDM1, and it's about 7:6 in sacituzumab govitecan. And then also very important, and it's very different from the TDM1 that we talked about earlier, is it have what we call bystander effect. TDM1 that we talked about previously, that drug when was designed, the linker, that is this little thing between the antibody and the blob, was created to be so tightly bound to prevent that chemotherapy bond from being released into the circulation, that once it got internalized into the cell and cleaved, though that chemotherapy couldn't leave that cell. The way these are designed is that when you cleave that, and you can see this on the right here, so the antibody gets to the cell, it's internalized and destroyed and cleaved, and the chemotherapy is released. That chemotherapy has the impact on the cell that internalized it, but it also seeps out of the pores of that cell, so that the cells close to them that doesn't express either TROP or HER2 are also impacted by that chemotherapy. All right, so what we see is what we call bystander effect on this. TROPiCS-02, first presented at ASCO, looked at a more highly pretreated population, at least having had 2 to 3 previous chemotherapy, whereas DESTINY-04 had 1 previous chemotherapy, and they randomized the hormone receptor positive patient population. This drug, sacituzumab, is also already approved in triple negative in the second and third line, but they were looking in the hormone receptor positive patients, regardless of HER2 expression, and randomize them to sacituzumab versus physician's choice of chemotherapy. Here we can see a lot of the patients have had, 99% of patients have had previous CDK4/6 inhibitors, chemotherapies, previously Xeloda, paclitaxel, eribulin. So it's really a highly pretreated population. PFS, OS, PFS was presented at at ASCO first, which showed that there was small, so the numbers are at 12 months, 5.5 versus 4 months improvement. So it's a 1.5 month improvement in progression-free survival. You may say, oh, that was statistically significant, but is it clinically significant? At the time when they presented San Antonio and ASCO, overall survival was immature and there wasn't an overall survival benefit. So the word was, yes, it does improve, but is it clinical? At ESMO, that following, they proved that there was overall survival benefit, and that was presented. And we see it here, 14.4 months versus 11.2 months. So those patients are getting clinical benefit in terms of control of the disease, but they're also living longer utilizing sacituzumab. In terms of toxicity, neutropenia was heavy in that population of patients, mainly a lot of hematologic, GI toxicity, nausea, vomiting, constipation were also some of the side effects there. Cardiac was not. We didn't see many of the ILD issues that was seen with TDXD. Now, the Gilead went through and looked at their population because TDXD for DESTINY-04 made a big splash at San Antonio. Because it essentially it changed the way we actually thought of and treated breast cancer. We now have a HER2 low group that we never fully considered and appreciated. So they went in and they said, we didn't specify HER2 in our drug. Let's go back and look at our tissue and take the HER2 low group, the HER2 zero group, and see whether or not there was also benefit for that group of patients on the trial. And it turns out yes. So the HER2 low, there was a median about 2.2 months improvement in median progression-free survival that appeared to be significant in the HER2 low and even the HER2 zero space using sacituzumab. So those patients who have hormone receptor positive or HER2 zero, this drug is an option for them. In conclusion, CDK4/6 inhibitor combination therapy are effective in high-risk patients, high-burden disease, such that really this is what we should be thinking about and not necessarily chemotherapy for our patients. T-DXd is safe and it's an effective option for HER2 low after exhaustion of anti-estrogen therapy, and sacituzumab should be considered for HER2 zero, ER positive in the second and third line space. I have used it where I would have used T-DXd in patients who have HER2 zero. And as I said before, that drug is also approved in the first-line triple-negative space, which data not shown. So the third case, and I'll end on that, is a 50-year-old female, an otherwise healthy woman presented with approximately 5-centimeter breast lesion discovered on routine mammogram. Core biopsy of this lesion showed a moderately differentiated invasive ductal carcinoma, ERPR 1%, HER2 zero, so essentially a triple negative patient with a PDL1, which was done of CPS 0. Traditionally, we don't do that on our curable patients, but that was done in this case. The physician thought that this patient was going to be metastatic. Imaging was negative for nodal involvement and distant metastasis. Genetic counseling did not reveal any BRCA mutation. She had a good performance status. So she was diagnosed with a stage 2 T3N 0. That's anatomic stage 2. A decision was made to initiate neoadjuvant chemotherapy based on current data. What is the most likely to recommend for this patient? Option is traditional chemotherapy, dose dense AC with paclitaxel, or AC paclitaxel weekly, taxotere-cytoxan times 6, or an immunotherapy type combination with anthracycline and cyclophosphamide and paclitaxel carbo, based on the Keynote 522 regimen. The answer right now is the Keynote 522. And this, again, for so long in triple-negative breast cancer, it was chemotherapy after chemotherapy. We still need chemotherapy, but what this study has done is allowed us to use a targeted, non-chemotherapy approach to improve the outcome for those patients. Pembrolizumab who doesn't know King K? Everybody should know that. It's everywhere. We put it in the water now. It is an immunotherapy that allows the immune system in its simplest form to sort of recognize the tumor as foreign and help in the killing of tumor cells. This study enrolled patients who were triple negative, who had at least 2 centimeters of tumor, with or without lymph node involvement, and randomized them to traditional chemotherapy, Taxol, carboplatin, followed by Adriamycin cytoxan, versus the same chemotherapy with the addition of pembrolizumab. And they took the HER2 trastuzumab approach and continued the pembrolizumab for a year after completion of chemotherapy surgery, with pathologic complete response being the primary endpoint. We also have data on event-free survival. What did it show? And on the left here, it showed that the patients who got the pembrolizumab in addition to chemotherapy had almost a 14% improvement in pathologic complete response. Meaning, if you give pembrolizumab with chemotherapy, we are more likely to kill all of the tumor within the breast. We do know from long-term data that PAV-CR patients who got a PAV-CR are have way better outcomes long-term in terms of survival. So those patients were doing better, although chemotherapy itself didn't do too bad. 51% of those patients had a PAF-CR, and on the right, we saw interim analysis 4, which finally showed that not only were those patients doing better from a PAF-CR perspective, they appeared to be better control of the disease at 3 years with an improvement, statistical improvement in event-free survival. So that is now standard for patients with triple negative. Subgroup analysis, and I think that's very important. Traditionally, we use this pembrolizumab drug or any of the immunotherapy in patients who are PD-L1 positive. In that study, we're using it on everybody. The question was the results that we see driven by the patients who are PD-L1 positive and not necessarily the ones who are PD-L1 negative, and we can see there on the second highlighted box, PD-L1 positive or negative, everybody benefited. All right? Node positive, node negative also benefited, and we have the data here. The patients who were node negative, the PCR benefit was much smaller than if you were node positive. So the higher risk patients tended to get better PAF-CR improvement, but everybody did. Exploratory analysis, so when we look at the patients who got PCR versus the patients who didn't get PCR, how did they do? So if you got a PCR, regardless of how you got it, with or without pembrolizumab, your potential for controlling disease, event-free survival at 3 years was very similar. There was 2% difference, 94.4 versus 92%. With or without the addition of pembrolizumab. So the question, and we had a discussion of that on our molecular tumor board yesterday, do we really need the adjuvant pembrolizumab on everybody? Maybe not. We just had, I think, Guepa-Nevo trial was published in Annals in November, and in that study, used durvalumab with chemotherapy in the neoadjuvant setting without adjuvant durvalumab, and durvalumab is a PD-L1 inhibitor. And although there was a PCR difference, there was an improvement in overall survival and event-free survival for those patients who got it in the neoadjuvant setting and not in the adjuvant setting. So, do we need it? It's a question that needs to be answered. But if you didn't get a PCR, you definitely needed it. And you can see the difference there, 67.4 versus 56.8. But most importantly, look at the difference between the curves for patients who get PCR and who do not get PCR. There's a big difference. There's a 30% essentially reduction in your ability to control this disease and not have recurrence. So we are not even close to having all the answers. So what do we do for those patients who didn't get a PCR? Overall survival, and we talked about that earlier, for the patients with chemotherapy versus not. So in this patient, she continued, neoadjuvant therapy was initiated, she got the Keynote 522 regimen, she had a complete pathologic response, but she continued pembrolizumab. In terms of side effects, looking at treatment-related adverse events in the combined phases, the darker colors are more grade 1, grade 2. The lighter ones are grade 3, grade 5. And we see nausea, alopecia, anemia, fatigue, those dominated the side effect profile for everybody. On treatment in the adjuvant setting, and so that was with chemotherapy, you can see that patients are doing better in terms of a tolerability in the adjuvant setting when you remove that chemotherapy to it, which is sort of expected. In terms of immune-related side effects, what was driven there was immune reactions, hypothyroidism, skin reactions, hyperthyroidism, so the impact on the thyroid. And those are not insignificant because you're destroying the thyroid, and now those patients are going to have to be potentially on thyroid replacement for the rest of their life. Even colitis, adrenal insufficiency. is also higher in the patients who've gotten the immunotherapy. So we can't take them lightly, that giving everybody pembrolizumab if you don't need it. Immune-mediated AEs in the adjuvant setting only, again, went down in terms, patients did better, but again, we see sort of the similar adverse events, although not as frequent in the adjuvant setting as with combined chemotherapy. So unanswered questions. How long do we continue adjuvant pembrolizumab for those patients? We talked about the Volumab study that suggests maybe we don't. And again, when I say the event-free survival, and that was a phase 2 study, the numbers were very, very similar. 84% event-free survival at 5 years. Are we convinced that pembrolizumab offers benefit for patients with PCR after neoadjuvant therapy? I would say now that I will give it. And the reason I'll give it is because we only have 3 years of data. We don't know what happens in 5 years. We don't know what happens in 10 years. And the data will eventually resolve itself. And if patients are tolerating it, give the patient the benefit of the doubt. If not, what more do we need to see? And we need to see more long-term data and better design studies. Also on that trial, we hadn't traditionally used carboplatin and Taxol. It was AC Taxol. And now we add carboplatin, so we added an additional chemotherapy. So we're really just throwing the book at these patients now that we didn't do before. In Passion, I think 31 was Genentech's similar design study that didn't use carboplatin. In that study, there was about a 15% improvement in PAF-CR with atezolizumab and chemotherapy versus no atezolizumab. We don't have event-free survival yet for that study. The other question is, does your overall adjuvant approach differ for the patients who didn't get a PAF-CR? What if they had a BRCA mutation? What do you do adjuvantly? Now we know that olaparib, which is a PARP inhibitor, has shown not only progression-free survival, but overall survival for patients who are BRCA mutated for 1 year of adjuvant therapy. Those patients live longer. What if you had a triple-negative patient who was also BRCA positive? What do you do in the adjuvant setting? Those need to be settled. We don't have studies to do. What I do is I combine them. I give them pembro. We have data in breast and in other tumor types, early phase studies that show it's safe to combine immunotherapy with PARP inhibitors. If insurance will allow me, I'll combine them if they didn't get a PAF-CR. Because you saw those patients if they're a 30% reduction in risk. There's more that we need to do. I combine them. What about the patients who didn't have a BRCA mutation, and they didn't have a PAF-CR? I didn't show that there because I thought time would be an issue, but apparently it's not. At ASCO last year, further analysis of the Keynote 522 study, they went through and looked at how the patients did based on RCB. And RCB is essentially how much residual disease. It's a measure of the amount of residual disease that you had after neoadjuvant chemotherapy, with 0 being a PAF-CR, 1 meaning you had a little bit, but it's more of a pathological description of it, and 3 meaning you have a lot. Traditionally, we know if you have RCB of 3 for triple-negative breast cancer, your chances of being disease-free at 5 years is only 30%. If you are 0, it's close to 90%, and it's very in between. And they looked at the PAF-CR, the RCB, and how those patients did, and it turns out, again, there is a difference for the addition of pembrolizumab based on PAF-CR, but the patients who got RCB3, those patients are not doing well, regardless of whether or not they got pembrolizumab or not. It's very similar, almost 70% risk of recurrence. So what do you do for those patients now? Knowing all of this, pembrolizumab is not the only answer. Traditionally, previously, we had the approval of Xeloda in that setting for patients. But we don't have combination Xeloda study in a large phase 3. We do have additional studies elsewhere that show that Xeloda and pembrolizumab safe to combine. What do you do? I know what I'll do. I try to combine them. It's not with data, but we do know that we're not there. Those patients need something more. And I've tried to combine them. I've been successful. I always almost have to do a peer-to-peer, but I am able to get it. So what I do is I combine them until I have data that tells me it doesn't make a difference. Because we know those patients, if they don't get a PAF CR, if they get pembrolizumab, they do better, but it's still not ultimate. So I do add capecitabine in there. And that's, I think, is it for my presentation, and I will take any questions. We have 11 minutes. And I'll talk about not only any drugs that I've presented on. If you have any questions regarding any other case, I'll take a question. Yes? Mm-hmm.
Have a patient of color in your practice, are you approaching them any differently? Are you diving any deeper? Are you taking the time to maybe talk to them about different types of options or different types of risk or outcomes that they're more prone to?
Thank you for that question. We do know that patients of color are more likely to be triple negative than not. So that is a large population of patients. The triple negative also are more likely to have a BRCA mutation than not. So we think of those patients in that aspect. From a choice of therapy perspective, no, because really at this point, all the data that we have is one size fits all, and it's the aggressive. But what I do talk to those patients about is about their comorbidities and the other social determinants of health, which can impact their ability to take their therapy and take their therapy in a timely manner. We talked about adherence last night also. If you're not adherent to the regimen, you tend to do worse. And so patients who, especially in our Memphis area, there's lots of diabetes, for example. So neuropathy is a thing that exists. Our taxanes, we give taxane with there, who gives a lot of neuropathy. I also showed data that some of the work that we did at West, just looking retrospectively at our data for patients who've gotten chemotherapy, white versus black patients, and just analyzed their symptoms at the end of chemotherapy, and it appears that black patients were reporting way more symptoms than white patients for the same sort of treatment, which then impacted the ability to complete their anti-estrogen therapy going further. So we do have those conversations about social determinants of health. How can we help make sure that you stay on your regimen? Because you need to take it in order to get the response, but also your side effect profile. What can I do upfront to sort of mitigate those so that we can help you get the good response, but also not the negative impact of the drugs. So thank you, very good question.
Hey, Greg, quick question. So the point of this question is, like, when we're taking care of patients in the hospital with their breast cancer that may be initial or more aggressive, and you talked about hormone receptor positive CDK maybe being better, then is there a time when we're taking care of patients in an acute setting that chemotherapy is better, or is that a good option even inpatient? I mean, does it work quickly? Or it works fast enough, do you feel?
Nothing works fast in breast. He's a liquid tumor guy. You know, you give chemotherapy and they all just shrink. I remember at my training, we're a big lymphoma center. So in Northern California. And so giving chemotherapy inpatient for a patient who's failing was a thing that we did a lot. In breast, we don't get that dramatic response. The response we see is in 2 to 3 months. And so giving them chemotherapy inpatient to sort of help reverse the course rarely happens. The times I do that is if you have a patient who's having aggressive disease and for some reason we really can't get them out of the hospital to get that next therapy, then I tend to start it there because time also matters. But most of the times we're doing it is not because we think it's going to change their course acutely. We don't shrink tumors that fast in breast. But thank you for the question. Any other questions? Thank you very much. You mean no questions on catnip? All right.
I'm a thoracic oncologist. Please forgive me for my ignorant questions. So now with so many approvals, how do you sequence this? Now you have pembro immunotherapy in the neoadjuvant. Let's take triple negative, for example. You have all these immunotherapy agents in the neoadjuvant space. Let's say they relapse, progress at a later time point. Now you have other agents, the SASC, TDX2, TDXT. They all have pneumonitis. They all have, I don't know. I'm just wondering how, in practice, you think about sequencing these agents.
So, that's a question that we have all the time. When we move those drugs up from the metastatic setting into the early setting, especially those drugs that are used. So pembrolizumab, for example, is a first-line therapy for PD-L1 positive patients in the metastatic setting in triple negative. But if you give it to them up front and they're progressing on it, what do you do in the first-line setting? And so we have to bring our second-line therapy up. Many times, depending on that disease-free interval, I bring sacituzumab up in the first-line setting because it's a second-line drug. So we have to make those decisions. BRCA mutants, olaparib is approved there. Talazoparib is also approved there, which are PARP inhibitors. So if those patients have BRCA mutation, but now olaparib is approved in the adjuvant setting. What if they got it? Now, what do you do in the metastatic setting? In triple negative particularly, it's chemotherapy after chemotherapy after chemotherapy. That's where we are, unless, or clinical trial. I would make a big push for clinical trial. We should consider those patients for clinical trial at every opportunity that we get, even in the early setting, because that's how we make those changes. And the way the trials are designed nowadays, there isn't an inferior arm. It's generally standard of care versus standard of care plus. And so when we're designing those studies, we're making sure, and the FDA also keeps us on our toes for that the control arm is not inferior. So I would push, and that's the way we're going to move this forward and get more and better therapies for our drugs. But interestingly, as a thoracic oncology, this TDXD thing and the ILD that we see in breast, I would have expected that in lung, you would see for somebody with lung cancer, so that drug is now approved. Yeah, it's a lower dose. We don't see that level of ILD, what is the dose? How much? It's a lower dose than breast? Yeah, because we don't see the level of ILD in lung cancer that we see in breast cancer, utilizing the same drug, except those patients have their disease in the lung, which was interesting to me, to say the least. All right. So that is a very, very, very important question. So it hadn't been standardized, so different practices around the country. And the question is, how do you classify those patients systemically in your clinic? As a practitioner, how do you identify those patients? Because we now created a different category for the patients who've been treated way back. How do you classify them? How do you get that so you know who's HER2 low? We strongly encourage our physicians to not say HER2 negative, to list the expression of the IHC. Our pathologists are doing that right now. What I do is, in my clinic, and for mainly OneOncology, I'm the chair of breast at OneOncology, we talk to our physicians and the pathology groups about making sure that you list that HER2 in your notes and wherever in the EMR so that you know which patient is HER2 low. I also encourage patients and physicians, if you have a patient who was traditionally HER2 zero on their early and you biopsied and you have HER2 zero and you have a chance to biopsy, those can change. Biopsy. Even with TDXD, there is phase 2 data to suggest that there is also activity in the quote-unquote HER2 zero. If you think about it really theoretically, there really shouldn't be a HER2 zero. HER2 is a protein that is used by normal cells for its normal activity. So almost every cell should have some HER2 expression. It's really what we call HER2 zero is the threshold of our testing. And so almost every cell should have some HER2 expression. And we do see that in HER2 zero, what we call the ultra low, maybe, and the response may be varying. What we see is about a 30% response for TDXD in the HER2 zero, and there's a study looking at that, and we'll get some more data. But, and one of the important things is there are some practices who only did FISH and never did IHC. And so you're doing those patients a really big disservice because you now have to go and test all of those tumors and report the IHC. So we have to change the way that we look at those patients and we treat those patients and report the results. Thank you, very good question. Yeah, so breast, we are 5.4. When we did in the Destiny 1, when we looked at 6, there was a lot more ILD, so we didn't use that. But we use 5.4, and we don't see as much in lung. It's left to be known. Why? Thank you. Appreciate it.